TopMedTalk.
Welcome to TopMedTalk, and this is part one of the Q&A session relating to Mike Grocott's talk, What is Prehabilitation? You'll find the link to that in the show notes for this podcast. This conversation is divided into two parts, and this is part one.
So we didn't make introductions of everybody early on, but Linda Denehy is a respiratory physiotherapist, an academic respiratory therapist in Melbourne, in Australia. And this is the grandfather of prehabilitation medicine, Franco Carli, who leads prehabilitation service in Montreal in Canada. And Gerrit, for those that don't know, is a colorectal surgeon who led the international prehab study in Holland, Netherlands. So thanks, Mike. That was a great talk. I'm going to see if we've got any questions through on Slido. Whilst we're waiting, I'd be interested in each of your healthcare systems. Do you, within your nationalised healthcare systems, do you as yet have recurrent funding to deliver multimodal prehab across Canada, across Australia? Do you want to start, Franco?
No, I don't think exists actually a payment at the moment recognized. We went to our CEO of the McGill institution and we asked to give us a certain amount of money to provide a clinic, with the understanding that we will come back in 3-4 years and give some preliminary results of the activities. And though we formulated very closely a referral list to the surgeons. So we don't have a very much universal, very few, but the majority are high-risk patients. It's 3, 4. And so this was the idea to come up with a justification. So that's my question about, I don't think exists. I think there are some data coming from British Columbia, where they've been working on errors as well. Errors and prehab sort of mixing together. And I think they were able to actually, at provincial level, were able to institute, but that's in the last, I would say, 2-3 years. So there is some movement. I would say we're really in early stages, in my view, in Canada, very early.
Thank you, Franco. And Linda, your experience in Australia?
Yeah, very similar to Canada. It's very patchy in Australia. It's certainly not national, and it depends on business cases, but we do have some good programs in different states. Our health is state funded as well as some national funding, so it is state dependent. So it does depend on money, system, business cases, and showing that it actually works. We have recently in Melbourne implemented some prehabilitation across an area of 4 hospitals to try and bring down the waiting lists, hospital surgical waiting lists, but again, patchy like Canada.
In Holland, there's quite a lot of hospitals involved in prehabilitation, but prehabilitation is funded mostly by local budgets or small grants for a limited number of patients per hospital, mostly not uniformal. However, there are 2 major insurance companies that do reward us for providing prehabilitation. They actually pay a bit extra over the money it costs to do some project management included. But it's only 2 insurance companies out of the 5 major ones. And everyone is waiting for guidelines. And that's the hard thing. It might take years until the evidence is truly there to put prehabilitation in guidelines. And we hope to speed that up, at least with our Dutch chapter of the society.
I'm not sure I can speak with confidence about what happens in the UK, not because I don't get out much, but because I'm slightly confused at the moment. So we, for example, in Southampton have been lucky enough to have a business case approved based on the Westbit trial, which was funded by our Regional Cancer Alliance, so essentially by NHS England, and showed a benefit. I'm not going to give away the detail on that, but showed a benefit that was convincing to our trusts that persuaded them that they would fund an embedded prehabilitation service as part of our perioperative medicine service. There has been, many of you will know, a paper based on the Freedom of Information request that suggests that the vast majority of trusts in the UK have funded prehabilitation services. And certainly there are quite a few places around Manchester being a really notable example that have very active services, although I think Manchester's funded by the Regional Cancer Alliance. But my impression from talking to people is actually that although the Freedom of Information request suggests there's a lot going on, quite often that's essentially it's universal interventions or sporadic interventions. And I'm not convinced. I'd be really interested to hear over the next couple of days how widely adopted prehabilitation currently is in the UK. And at the moment, part of the challenge is we don't have a tariff or a direct funding mechanism that says you can have this for doing prehabilitation. It's on a trust by trust or integrated care board by integrated care board basis.
Thanks. So I've got some questions coming through from the audience. Given that there is increasing level of evidence, Helen asks, how do we speed up the application of our evidence for prehab into action, avoiding the postcode lottery of enthusiasts, which is, I think, what we have at the moment. And I was amazed by that Freedom of Information Act in the UK. I do not think, from speaking to colleagues around the country, that 75% of trusts have a prehabilitation service. They may give out a leaflet, but I'm not sure that's the same thing. And often, if they do have a prehab service, it's often in small numbers of patients. So
postcode lottery is one of our sort of favourite cliches in the UK, but it's often true. Different postcode zip codes have very different delivery of care. I mean, I guess our hope would be that NHS England, and there is now strong perioperative medicine leadership with NHS Link England, within NHS England in the form of Brahmini Singer, who's the National Clinical Director, who's very supportive of this type of thing. The hope would be for a kind of national tariff and or national guidelines that would drive change across institutions more widely and facilitate those who want to set up services. I guess the problem at the moment is there's quite a lot else going on in the health service in the UK, and I think it's a real struggle to execute policy change and effect change from the NHS, and hopefully that will change soon.
Any thoughts from other panel members? Tips for implementation more widely? No?
You know, I really enjoy your talk, Mike, and touching bases. You know, I started with ARS years ago, many years. And I came up to the Prehab really thinking about there was something missing in the ARS. And was this basically the surgeons and the anesthesiologists, the nurses were very involved in the intraoperative, immediate perioperative care, but perioperative care, but very little about preoperative care. And coming from a culture very much of, say, what is important for the patient to arrive to surgery? What condition? And that's what I think was an evolution for me. And say, this is a gap in the system. And that's where we are really scratching at the moment. It's only not even 10 years that we're really developing, thinking, studying this. You know, Gerrit lasted 25 years and it's still, ARS is not applicable anywhere. So I want to be more optimistic and say, yeah, we need to develop. There are so many questions. I think the procedure specific, for instance, you can't just give out, prehabilitation. What type of prehabilitation you need? And that's where it becomes much more, in a way, granular. And we're learning that. So, and the last things I want to say, that's why I just want to say, is the value. We talk about value. But really, do we believe the value is only the fact that it costs less for the hospital? That's the barrier we have with the hospital institution. The interesting, what is the cost? Now, I don't think I can reduce our... Now, 50% of the patients doing colon surgery, now they go home in the afternoon. Lung, they go some in the afternoon. Even patients with some. That's why, it's difficult. And I think it will be interesting to actually discuss or test the all surgeons, and I would say probably the one who are involved in economics, to say, what is the real value from the patient's point of view? How can we materialize? How can we cost? I think, and this is the recovery. So, in a way, I don't know what I answer to your, but this is my sincere, optimistic, and to some extent, waking up, guys. There is more work to do, and I think that we can do it, but it really involves a community altogether.
I don't know whether this is an answer to questions, but all we are trying to do is speed up the process, because there will be a place for prehabilitation in the end. But will it take 10 years, 15 years, 20 years to get there? One of the things that changed is surgeons, anesthesists, and all other disciplines started talking to each other about perioperative medicine. Not for long, our anesthesiologist believed that ERAS was something for the surgeons for postoperative care, and not realizing that actually they had the major task in all that ERAS was. It is unbelievable that in different sides of the world, it is surgeons that are the stakeholders that try to push prehabilitation. While in Canada, the UK, Australia, it's the anesthesists that do so. And it seems like it's two conflicting worlds finally getting together. And then in the end, the discussion of implementation is always about money. And that's the big pain. It is about money, and we forget the benefit for the patient.
I think there's a lot still to do. And, as Mike pointed out, lots more research about the components of prehab, about the cost effectiveness or value for money of prehab. But we need to collaborate more globally, I think, to get answers a bit faster and introduce some implementation work within our research so that we can speed up that implementation process and work towards guidelines.
Yeah, we're having a session later this afternoon about standardisation, because one of the problems of the literature is it's often difficult to tell from the studies what tools we used, what screening, what the actual intervention was, and we can't hope to replicate unless we are standardised in what we're doing, at least to test interventions. So the more questions are coming through. Somebody's keen to know the panel's thoughts on whether we can define an intervention during a treatment, e.g. chemo, as prehab, or is that rehab? So this is again about definitions. When does prehab become rehab? Linda, you laughed. I'll ask you.
I laughed. So, it's a continuous process, is it not?
Yes.
There's really not a lot of difference, perhaps, in the components of what you're doing. It's more about how you define it, I think. But certainly from a chemo point of view, there's batches of chemo. So, does it start with prehab and then become rehab? And then it's just a continuum of process, I think, around. It's about definition.
Yeah. And the workforce can be the same sometimes.
Yeah. Yes.
Any other thoughts about that?
Yeah, the question, who is doing it?
Yeah.
I mean, we start, of course, as a kinesiologist, as an anesthesiologist and surgeons, that's fine. But I think this is where the community comes in. From the beginning, that's the general practitioner, family doctor, should be involved more and probably continue, because definitely we are limited and the system becomes fuzzy. The liaison is different. In Canada, there is no liaison between the hospital and like you have in UK, the GP. So really, very much depends very much on the individual country, individual health system. But definitely the community, continuation of the community, to some extent will be very useful.
But difficult, certainly in Australia, with community and getting GPs involved.
I started this by talking about problems, and it's easy to identify the problems, but I think in comparison with only maybe 10 years ago, when a significant portion of oncologists and even sometimes surgeons would say, we can't possibly exercise them, it's just not safe, that's completely gone. I think we've come a very long way. There's starting to be lots of really interesting data, so I agree with all three. We're in a good place, and it's about speed of implementation now and gathering the important evidence. But it's a positive message, not a negative one.
Yes, well, I think I would agree with that. So 10 years ago, everyone told us the patients didn't want to do it. It was unfeasible. It wouldn't work, and there was no evidence. And I had a pro-con debate somewhere in the southern hemisphere with a surgeon who said, he wasn't interested in 4 meters on the 6-minute walk test, which actually I have some sympathy with. He wanted a hard clinical outcome. But I think we've moved, if you look at the literature, just put prehabilitation in PubMed and look at the explosion in papers in the last 5 to 6 years, we have come a long way. Somebody was just about to ask a question over here.
Hi, Dr. Chanaka Karunaratna, one of the senior consultants from Mid and South Essex NHS Trust. To tell you frankly, I have loads of experience in preoperative assessment. I started a unit in Basildon University Hospital in 2016, and it became a vascular center over the years. Right? Okay, so it's a regional vascular center. And I just would like to, the biggest question that we have to all answer is prehabilitation works. That's the biggest question that we would like to answer here. Now we have a robust plan to identify aortic aneurysms coming for open very early when they are about 3.5, 4.5 centimeters. So straight away, without even funding, sent to the preoperative assessment, and we do a straight away CPEX testing. And to tell you frankly, and then we have more time to prepare them, and I put them on an exercise regime. Obviously, it's not state funded. People have to fund themselves. A nutrition program, they have to fund themselves. I just want to collect data so that it can be presented as a business case to the trust in the future. To tell you frankly, within about 3 months or 4 months, maybe 6 months, I can see the difference because anaerobic threshold increases drastically. And I can give you an example. Once a patient came in, he was BMI 46 when he came in. I put him to prehabilitation program with nutrition, exercise, and his anaerobic threshold at the beginning was 10.5. It increases to 12.5 after 6 months. And he had successful surgery and went home next day. So it works, but the problem is we are at elementary state and it needs lots of funding and thoughts because in the long run, it can save money to the NHS.
Thank you. I agree. There's lots of experience in that format. John, do you want?
Hello, John Consulate, United States. I'm a regional medical director for HCA, and I'm in charge now of developing ERAS programs for our 180 hospitals. Thank you, Mike, for the talk. I have a couple of comments and then some questions. To the very young man on the right, I agree with you. I believe that prehabilitation is and should be an extension of ERAS. We haven't quite done that yet. Mike, you mentioned the comment about value. For those who want to read a very good article, there's a surgeon from Utah that wrote an article. His name's James Pendleton, about how do we determine value in healthcare. And I think we've all become fixated on money and outcomes. Really, we need to get together with the patient as well. And our surgeon colleague up there mentioned all of us need to get together with all stakeholders. Patients should be included in that in determining what is truly value. So the two questions I have for the panel, number one, in ERAS, that is mostly practitioner dependent. Prehabilitation, to me, appears that will be patient dependent. So how do you motivate and make the patients accountable for doing prehabilitation is question one. And Mike, to your graph that you showed about prehabilitation, it looked like on your y-axis, the patient was at about a 75 percentile of general health, and you had a number of graphs going for prehab, et cetera. What do you do when you get that patient in the 25 percentile, which we get many of that have not had care at all because of COVID? They haven't gone to their physician for 2 years, and they come with their end-stage diseases in even worse condition, but they still need surgery.
Can I comment on motivation of patients? Because that was our major concern when we started the pilot doing the prehabilitation program. But the problem resolved because the interest from our patients came from the patients themselves. Sometimes our patients are seniors, so sometimes their peers have to take them to the hospital and back. But these patients became enthusiastic. There's complexity of processes taking place. By doing exercise, they create dopamine and get in better shape and feel happier. All these factors working together. So we found that we didn't have to motivate our patients, especially now since all patients get prehabilitated. We just tell them that the program starts with getting fit for surgery as soon as they heard of their potentially terrible disease. So we don't need to motivate the patients, they motivate themselves. And as soon as they start training in a group, they definitely motivate each other. And over 90% of all planned sessions in prehabilitation are attended. So motivation isn't really the case, I've found.
And I agree. And we do actually include our patient voice in most of the things we're doing. Certainly at Peter Mac Hospital in Melbourne, in Australia, we have a patient portal. We have great feedback from patients, which we put onto the portal. There's group sessions that motivate patients as well. We don't have a big problem with motivation, but we do include the patient voice in co-designing programs for prehabilitation and also in what's important for them in outcome and measuring outcome.
Well, I think the role of the surgeon is very important in the referral, because definitely the surgeon will be the first to take care of the patient and will see him in the clinic. And as a surgeon, I strongly believe, and there are many surgeons here, definitely they know the clinical aspect. They know when the patient is malnourished, when the patient is to some extent from the history and also the gravity, whether they have to go for neoadjuvant and so on. So I believe that the referral will be very useful from the surgeon who is very involved in this, definitely. And we see the surgeons are becoming more and more involved in this, which is important. Now, from the patient point of view, well, look, if you are given diagnosis of cancer, I don't know in different parts of the world, but if you are given cancer and by the surgeon or the tumor board and so on, you're left on your own. You don't know what to do. You just wait. So this concept of engaging them, and that's where their referral, we want to engage you. There is an engagement platform we're giving to the patient. That changes completely the dynamics. You will have a 20, I would say the Gaussian curve. Basically, you will have a 70% who will be really happy what's happened. Some would say, no, we know everything, we do everything, we're okay. And the one who actually don't want to, or they're extremely excited about, and they write letters at the end. So you have the spectrum there. I believe that the engagement comes from, remember, issue of psychosocial. If you're poor, if you have transport problems, if you have extremely intelligent, educated. So really, our hour is to identify those patients who really need more help than others. And that's where I think the dynamic we are learning. I'm learning very much from this now. And that's why it's the errors and beyond the errors, the collegiality of the group.
Well, I think, as you say, prehab is meant to be about supported self-management. So you need different patients need different levels of support. And our experience from asking patients is there were some common themes from Sandy's work in Southampton and a series of trials. Within the trials, we had adherence of over 90%. Clearly, within trials, you tend to have a healthy bias, so it's not necessarily that bottom 25th centile, but some of them are in that. But what we found is adherence is extremely also poor if you leave patients on their own. So just giving them a leaflet, waggling a finger, not implementing and using the behavioural change techniques we know, improve adherence will not be very effective. Most patients are a little bit scared when you're talking about the bottom 25th centile. Our experience is that they're a little bit anxious about exercising, so they want supervision. They would quite like to do it in a group. These are recurrent themes we've had over and over again, or with some friends, because there's psychosocial support and it's nice to do that. And they would prefer not to come to hospital. They'd like to do it near home. But in home, on the whole, when we let people go on their own, there's been less adherence. So even patients that we transition from an in-hospital, so the same patients, in one of Sandy's studies, Sandy then had a personal trainer to give them an individual program with apparatus, and they went home and the adherence went from 90 to 8%. So this is part of Mike's concern about the universal prehab and the sending off with a leaflet. Patients do need support. So that would be my thought on that.
Nobody said teachable moment so far, so I'm going to say teachable moment. But I think it's important. I think, John, to your question, those who are least fit probably have the most to gain. And certainly objectively, when you measure CPET or whatever your chosen measure is, they improve the most dramatically. And I think most of what we do is simply removing barriers. I think at the teachable moment, most people become very focused on their own health, and the empowerment piece I think is very important. But you've got to enable that for them and let them do the supported self-management. So allow them to do it closer to home, sort out the transport, give them a buddy so they're not feeling lonely. But I think it's mostly about removing barriers as opposed to in letting them do what they want to do.
Another question, what are the value metrics that have worked with policymakers and funding bodies? And which ones would you like to see used more? That's from Jenny saying. Anybody want to comment?
I don't want to talk about money.
But if we don't talk about money, it's very difficult to change the system. We live in an environment at the moment where that is what makes things happen in healthcare.
Yeah. From our experience in Southampton, where we now have recurrent funding in the NHS, it was about length of stay, critical care bed utilisation, so they were improving flow through the hospital by reducing length of stay, by reducing critical care lengths of stay, also by reducing on-the-day cancellations from people coming at the last minute. So those were the three major elements that went into our business case. They were pleased with quality of life, but they were more interested in the financial bit from the others, because you get heavily penalised for last-minute cancellations in the UK. And the other thing they were very persuaded by was patient stories. Individual patient stories of a very good outcome from prehab. And we had a patient who's done a very motivational 5-minute video that one of Sandy's patients from one of her studies, and those help as well. So I think you have to have the patient story and the quality in life and empowerment. But right this minute in the NHS, certainly, it's about elective recovery, more patients through, flow.
Add complications and return within 30 days to those.
So yes, emergency readmission.
Yeah.
That's also very expensive.
Maybe it could be useful to actually guiding people a little bit if they want to, assessing the risk initially. When you actually say to the palliative surgeon, this is the risk, and there is an SQIP risk, which gives an indication not only of the risk assessment. So it is very well utilized, and then you have, to some extent, a length of stay. That will help you, because you may probably be able to not to send, according to the NSQIP, which is millions and millions and millions, so it's pretty reliable, gives you 7 days length of stay, and then you are able to send out, 4 days, 6 days. Already, I think you have a proof, potentially, that this could be a very useful argument based on what is called recognized standard. So we have to be very creative in finding, but absolutely, we have to talk about money.
Thanks for listening to TopMedTalk. Make sure you've subscribed so you can hear part 2 of this Q&A session.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.